guys, it's Layla. Today we'll speak about Lichen planus. It is an acute or chronic recurring inflammatory erythematous dermatosis involving skin and or the mucous membranes. In people aged 30 to 60, more common in females, and it is idiopathic in most cases. This is what it looks like. Drugs or metals like gold or mercury or even infection, especially hepatitis C virus, which result in the alteration in cell-mediated immunity because you see lymphocytic infiltrates rich in CD8 and CD45, which are memory cells. There could also be a HLA-associated genetic susceptibility. Clinical features, you need to remember the 4 Ps or the 5 Ps. So it is papule, purple, polygonal, and pruritic, and the 5th one can also be plaque. In the mouth, they usually ulcerate. Wickham striae are white lines, more common in dark-skinned people. On the lips, you can have a linear arrangement after a certain kind of trauma, and this is known as Koebner or isomorphic phenomenon. Then there's post-inflammatory hyperpigmentation. It's quite common, especially in dark-skinned people. It can become generalized, which will include the wrists, lumbar region, shins, scalp, and the genitals, even the abdomen sometimes. So you can have a hypertrophic variant, which is common in black males. The lesions usually become hyperkeratotic and they appear on the hands and the shins. Then there's an atrophic variant, which is white or bluish in color. It has a central atrophy. It can present with alopecia as well. Pigmentosis, which is hyperpigmented as the name suggests, dark brown macules in sun-exposed areas. Ulcerative is therapy-resistant ulcers, mainly on the soles. They require skin grafting. Reticular is a net-like or a reticulate pattern of white hyperkeratosis on the buccal mucosa, the lips, tongue, and the gingiva. They can also affect the nails with longitudinal splintering. There are forms like follicular, vesicular, and actinicous. Follicular can present with alopecia as well, and you have typical skin lesions. For vesicular, bullous lesions, which can resemble bullous pemphigoid. And for actinicous, it's usually in the sun-exposed areas, mainly on the hands and the arms. Lichen planus like eruptions, they are lymph node lesions, most often due to chronic graft versus host disease of the skin, but can also be due to dermatomyositis and malignant lymphoma. They mimic both clinically and histologically, so it's quite difficult to differentiate. Diagnoses can be confirmed by histopathology because of some specific features. For example, you have hyperkeratosis. This picture explains it quite well. You have increased granular layer, which is hypergranulosis. You have irregular acanthosis, which is the epidermal layer. Keratinocyte apoptoses are called Sivot bodies, and they are found at the dermal-epidermal junctions. If you do a direct immunofluorescence test, you can see heavy deposits of fibrin and immunoglobulins. To find out the cause, you can also do a hepatitis C test and also an allergy test. Cutaneous lichen planus usually persists for months, but in some cases it can go up to years. Differential diagnoses includes chronic cutaneous lupus erythematosus, you can have psoriasis, pityriasis rosacea, eczematic dermatitis, and Bowen disease, lichen simplex chronicus, Kaposi sarcoma. For the mucous membrane differentials, you can have leukoplakia, candidiasis, secondary syphilis, and pemphigus vulgaris. The local therapy, it includes topical glucocorticoids like triamcinolone. Systemic therapy includes cyclosporin, glucocorticoids. You can also give them systemic retinoids like acitretin. H1 blockers, antimalarials, vitamin therapy can also be given. Puva photochemotherapy for generalized lichen planus or ones that are resistant to the topical therapy. Physiotherapy, where the adrenal glands are magnetically stimulated. Depending on the symptoms, give antipruritic, emollients, or resorptives. Okay guys, that is it for this video. I'll see you later. Bye.